such an example. So another round of applause, ladies and gentlemen. Thank you. So I wanted to seize the opportunity as well, and Dr. Amit was asking where are we from in the continent. So I'm Dr. Mary Musa, I'm head of consulting, and I always say I'm Egyptian by genetic, but I'm East African by epigenetics. So I have been living and working in East Africa and also Central Africa for the last decade after I graduated from mid school. Please do not calculate my age. But yeah, today I'm here with you, trying to advance our ways to reach universal health coverage. So I wrote a little bit of keynote speech on the plane, so hopefully I can read my own handwriting. So I wanted to share with you a little bit about myself, that I wanted to tell you that half of my time I try to find the missing link and create meaningful partnerships between private sector and public sector. And as we can see lately, private sector is in the continent to stay. Private sector means sustainability. Private sector means supporting local businesses and offering job opportunities. So this is my focus area when it comes to healthcare availability in the continent, where we want to reach sustainable and scalable public health systems through the private sector. And this is why we are here today with representatives from all those entities. So in the other half of my time, for those who know me, I sound like a female version of Thomas Sankara, but you'll get used to it. I'm very proud to be part of the AHB team today. I stand very proudly of all of the achievements that we have conducted through not only our efforts, but the collective efforts of our partners as well. I'm very proud that AHB is part of the force that is driving change around the continent. As we speak, AHB and the consulting team is driving and implementing over 12 projects all over Africa, which some of them are targeting last mile distribution of vaccines, economic modeling, assessing advanced treatment modalities for sickle cell disease and other NCDs. We are also spearheading policy advocacy and conversation for adapting and changing regulations. We are also offering for our partners go-to-market strategies for digitization, even though that I'm reading from my handwritten notebook, but we still support our partners. All of that, and many to follow, where we provide evidence advancement in the healthcare ecosystem around Africa. In our vision, comprehensive healthcare goes beyond the usual definition. We actually believe that it revolves around a holistic solution that is built by local experts, which we have abundance of. Even with the brain drain that Dr. Amit has mentioned this morning, 20,000 and more of us are outside of the continent serving other countries, which is very okay because we are a generous population as Africans, but we still have brilliant minds, specifically in this room. We believe in availing solutions based on our community needs and the indigenous knowledge, and specifically tailored and designed based on each community need. We have heard and we have here representatives from around the continent, from the north, from the south, from the central parts, but even within the same country. We are very aware that solutions that work in Nairobi cannot work in the arid and semi-arid area. We are aware that solutions for universal health coverage that works in Abuja cannot work in Kaduna. We are also aware that systems that can work in Kinshasa cannot work in Goma. So that specification of solutions can only come from our experts. So we're hoping in today's sessions titled Comprehensive Services and Quality of Care that to achieve universal health coverage, that we will shift our focus from merely the access alone to achieving full spectrum of inclusive, equitable, and holistic solutions that tackle issues of public-private partnerships, the funding ecosystems, and the financing issues that we are facing at the moment. Also designing holistic programs that not only target health issues, but also the social and the economic health determinants, which are essential. We can provide the best of service, but if there is no buyer for our service, it's in vain. So without further ado, allow me to welcome our keynote for this session, Professor Dr. Philip Abidin, the head of Tertiary Healthcare Standards Committee from the Federal Ministry of Health.
Thank you very much. Good afternoon, or is it good evening, everybody? Let me first of all express my appreciation to AHB for coming to Nigeria. Because this is the first time you are coming to Nigeria. And I think I need to thank you for that. I've been to most of the countries I've been hearing about here. Kenya, is it Nairobi, is it Uganda, is it Tanzania? But now for the first time I'm seeing all of you here coming to Nigeria. So Africans discussing African health and African problems. I think it is very impressive and I very much appreciate it. And I thank you also for inviting me to come and speak here. The issue for today is very important. Universal health care, which must be comprehensive. But it cannot be comprehensive without having standards. This must be with quality. Standard quality health care. And therefore, it is my honor to discuss with you as the chairman of the Nigerian National Tertiary Health Institutions Standards Committee. That is a committee formed by the National Health Act of Nigeria of 2014. And the purpose, the mandate, the core mandate of this committee is to ensure that Nigeria's tertiary health institutions, that is our teaching hospitals, federal medical centers, and specialty hospitals, meet and sustain the highest standards of quality, safety, and efficiency. This is important, I'll tell you. We've talked about primary health care, secondary, tertiary. Now it's important that these people go to the tertiary hospital for one thing or the other at the end. But unfortunately, even to my own experience, I speak with my aunties, my uncles, I see how some, even when you think I'm old, they are scared to go to tertiary hospitals. Once you say, take that person to that place, he will beg you, I don't want to go and die. This is the honest truth. Because they believe when they go there, they are going to die. Different reasons. One, they go there late. Very late. They prefer to go to all quick healthcare workers before they go there. So when they get there, everything is late. In most cases, we have to accept that. But even then, the quality of care in that place must also be standard. And that is how you see different people saying they are doing one thing or the other because they are not being monitored. We have the medical council, but that's when you report to them that there's a problem. They go there where academic, I've been part of it. Postgraduate medical college, pharmacy, this, we just go there, look for some certain things. Do you have this, do you have that? We go, but what is the quality of care? The person who can tell you that is the patient. It is the patient at the end of the day who can tell you, how long did I stay in this place? How long did it take me to see a doctor? How long did it take me to this and that? And that was the purpose of establishing the National Tertiary Health Institutions Standard Committee. Our vision is to transform these institutions into centers of excellence capable of delivering world-class healthcare, driving medical research, and training the next generation of health professionals. The committee also has the mandate to regulate organ tissue donation and transplantation in Nigeria. You read newspapers almost every day, somebody will say he has transplanted a kidney somewhere. Who monitors? I've done this and that. Who monitors? Just people just getting up everywhere and doing this and doing that. And so this committee also has the mandate to regulate this. Our mandate, this committee is an emerging one. As we work to develop, review, and enforce standards for infrastructure, clinical care, administration, and training in tertiary health institutions. Through assessments and accreditation exercises, we ensure compliance with national and international benchmarks. We talked about partnering with the private sector so that the government is not doing everything alone. And so we are partnering with organizations. Some are here, accredited by International Society for Quality in Healthcare, ISQA, to enhance healthcare quality across Nigeria. As part of this initiative, we are implementing structured tiered rating system, such as levels 1, 2, 3, 4, and beyond for healthcare facilities. This approach goes beyond assessment, as it also provides support to help facilities progress through each level and achieve higher standards of quality and safety. That is, you are on level 1 today. We also try to get you to level 2. What do you need to do to get to level 2? From level 2, what do you need to get to level 3? What do you need, and so on and so forth. We believe that our tertiary institutes have to be so equipped. I had a cousin of recent who just had a fracture about 2 years ago. She refused to go to where she will be taken care of. Preferred to go to local people to do this and do that. Today she cannot. She still had to be using a walker to move around because she was scared going to these tertiary institutions. And in March 2005, the committee introduced the guidelines for organ and donation transplantation in Nigeria. This is the first time we're introducing that. That has guidelines on who can do it, transplantation. This is the guidelines. And who can do it? Who is allowed to do it? What must be the quality of that person? What must be the qualification of that person? Who can donate? Not just going to, we have people, whether true or false, being kidnapped here, being doing this, that, or accidents and this and that. And we have, not only in Nigeria, in other parts of the world, organs being removed. And just, so this contains all the guidelines to do it, who to do it, where to do it, who can donate, who can receive. Just to ensure standards, clinical excellence, and strengthening laboratory protocols, and defining workforce requirements to support safe and effective transplantation services in Nigeria. Our next line of action is to bring and begin the accreditation and monitoring of our organ transplant centers across the nation, ensuring that they comply with laid down standards. Efforts are also ongoing to build partnership and capacity to establish an organ donation and transplantation registry. Our commitment is unwavering to ensure that every Nigerian, regardless of location or status, can access quality, safe, effective, and dignified health care at our tertiary health facilities. We are making significant strides, but we recognize the journey ahead requires sustained effort, innovation, and partnership. And we are therefore calling on you to partner with us in several areas. Technical support, we seek partnership to strengthen our international frameworks, adopt best practices, and leverage high digital health solutions, funding and investment, support for infrastructure, upgrades, research initiatives, and training programs is critical to our mission. Knowledge exchange. We welcome opportunities for exchange programs, joint research, and shared learning with peer institutions across Africa and beyond. Collaborative works. Let us build network, a continent-wide network, where knowledge and innovations are shared for the benefit of all Africans. In conclusion, as we gather here, with a shared vision for a healthier Africa, let us reaffirm our collective resolve to drive progress in healthcare quality and standards. The challenges before us are enormous, but so too are the opportunities available for innovation, collaboration, and transformation. This platform is an opportunity for each and every one of us, and I want to thank you. Bless you.
All right, thank you so much, Professor Abidan. We really, really appreciate. So one of the reasons we are here today, it's beyond having the same conversations over and over again. I want you to think about this forum like an open classroom where we exchange ideas, we exchange experiences, and believe me, it's of the highest value, because our people are almost the same, our community is the same, our experience is the same. So let us not reinvent solutions or borrow solutions from countries that has different ecosystems. And that's why I want to welcome our next speaker. Again, instead of long speeches, we wanted to have a case exemplar from Egypt, which you can audit, which you can adapt. We want us to share collectively. Allow me to welcome Mr. Ahmed Osman, the Regional Partnership Manager for Access Health International, to join the stage. A round of applause, everyone. Welcome, Ahmed. And he's also representing Honorable Minister Hala Zayed, the previous Minister of Health of Egypt, and he's going to share with us a few experiences. And please feel free to go to him, ask him questions, try to think, try to evolve, and also read the tertiary healthcare guideline. Again, audit it, give feedback. Let's be proactive about our health. Thank you. Ahmed, to you.
Thank you, Mary. So, take your time. So, welcome again. I'm Ahmed Osman. I'm representing Access Health International. But today, I want to discuss with you what we have done at the Universal Health Insurance System in Egypt. I was a part of this system since we have invented the law. But I would like to begin with a Latin proverb. So, one of my professors at Harvard University has always said to me, it's called Salus Populi Suprema Lexesto, which means we should make the people's health our supreme law. So we shall all work to make the people's health our supreme law. Let me take you through the journey of what happened in Egypt regarding the universal health insurance. The Egyptian system on the first place was very fragmented. We have a hospital affiliated to many ministries. We have the university hospitals, the hospital regarding the military, the Ministry of Interior, even the governorates have its own hospitals. So we decided to make the Suprema Lexesto. We decided to make our law number 2 for 2018, which we founded the 5 authorities for the universal, sorry for this because I keep moving the mic. We founded the 5 authorities for the Universal Health Insurance Project. The first authority is Egypt Healthcare Authority, which is the authority is for providing only the healthcare provision. The second authority is the Universal Health Insurance Authority, which is responsible for only the funding, and we have the General Authority for Healthcare Accreditation, only for making the standards and making the quality assurance of all the facilities are following the same quality standards. Also, we have the Egypt Drug Authority and the Unified Procurement Authority. By these 5 authorities, we have reformed the system itself. We began from scratch. We began unifying all the service provision to be under one umbrella. And the payer will be one person. It is not a tax-based system. It's a very complex, if I can say, or a compound system, which is composed of some of tax-based, of course, some of co-payments, some of premiums, and we collect all of this under one umbrella, and then we pay this to the Egypt Healthcare Authority. Also, regarding the phases, we didn't make it in one phase. We make it on 6 phases. Each phase is 6 governorates, and we finish the first phase, and the Universal Health Insurance Project shall be finished by 2032. The difference between the old system and the new system is the out-of-pocket expenditure. You can imagine that some governorates have a 60% of out expenditure. Now it's 24% only. So it's a mega change. And also we have included many private entities like Shifa Al-Urman that we have here today. It is also included inside the system. They provide our patients with the oncology services. So we are also including the private sector. Of course, the prices is not like they are having in the private. It's a challenge, but they are providing the service at the end. Actually, where is Andy? Andy was here. He was speaking about inventing the wheel. We didn't invent the wheel. We have imported the wheel in a way. We have seen the NHS in UK. We have seen the Universal Health Insurance in France. We have seen in Japan. And we have created our customized health insurance system. Until now, I see it as a success story. The Egyptian health insurance system is very old. It's from 1965. But at the time, it only includes only the governmental employees. But now, with the universal health insurance coverage, we can include anyone, even the poor people that have no money to pay. They are also under the umbrella of the universal health insurance. One thing which is of the most important thing is that you need to have the right persons to implement and to design and to take care about the system in a way. We shall know or we shall have this kind of knowledge from inside Africa or from outside Africa to be shared. And as Egypt, as African on the first place, we are not North Africa, sorry, we are not Middle Eastern, right? As you said, Ahmed, we are African on the first place. We want to share this experience with all our African family. We shall give this experience to them. Actually, Africa is a one unit. We can have this kind of compound system, if I can say. So our health insurance system in Egypt can be complementary with our health insurance in Congo or Cameroon or Liberia or wherever. By the way, it's very easy, but we need to have the will first. If we have the will, we can make it. The will is the most important thing. In Egypt, we had the political will. So also, I recommend to all my African family, please find the way and find the will to implement this kind of projects. It will benefit economically and health-wise to the people more than you think. And it differs actually more than you think also. So thank you very much all. I hope I have give you some sort of a little bit insight, and feel free if you have any question. Thank you all.
And we shall find the will. And I think I'm saying the word proud too many times today, but I am proud. Again, I'm proud of a partnership with a hospital that we're going to view a video about right now. And in this partnership, a hospital, again, from Egypt, yes, we are trying to bring them back to the continent, that are leading a conversation about clinical trials on the African genome and the efficacy of the current treatment. They are leading the way also on oncology capacity building. They are leading the way for a pan-African registry system for oncology patients. I'll ask the media team to show us the video. Thank you. A round of applause, everyone. Thank you. So without further ado, we are ready to hear this conversation that is going to be led with what I call the big four in the continent. The coming panelists include representatives from South Africa, from our host country, Nigeria, from Kenya, and from Egypt as well. So allow me to start with our host, Ms. Vivian Hikawizu, the Managing Director of the Nigeria Health Watch. A louder round of applause, everyone. Thank you. And followed by the Iron Lady herself, an inspiration for us all as well, Ms. Mukadi Mashishi, the country lead for Africa Market Access at Organon. Mukadi, please come and join us. Mukadi is also leading the inspirational coalition of women health in Africa. Thank you for your effort, Mukadi. Thank you. And we have seen one of the leaders, of course, in healthcare service delivery, represented by Mr. Rashid Kalani, the CEO of Aga Khan University Hospital in Nairobi. Please welcome him. Followed by, last not least, Dr. Nashwa Kordi, the head of biostatistics and epidemiology at Shifal Orman Oncology Hospital, all the way also from Egypt. The conversation is going to be catalyzed and led by our very own, and I allow me to say our own, because also I consider Kenya home, Dr. Jacqueline Kitulu, the president-elect of World Medical Association. A very big round of applause, everyone.
So good evening, good afternoon, everyone. Good afternoon. I thought you had all gone to sleep, but you can't sleep in this cold. It's pretty, the AC is pretty high. But very delighted to be here with you and this wonderful panel. We can still call it a panel. There's one man in it.
I feel discriminated already.
Yes, so earlier on, Dr. Amit looked and said, there's too many women in that panel. I said, this is just where it used to be, just a little reversal of it. So this wonderful team are going to discuss something that is really close to my heart, and that's comprehensive services and quality of care for attainment of UHC. I think for a long time, UHC has been focused, the discussion around UHC has been focusing on access. But we need to reorient that discussion, because beyond access, we need to prioritize the provision of the full range of quality health services. And that has to include the promotive, the preventive, the curative, rehabilitative, and palliative care across the individual's lifespan. This is very close to me. I am a practicing family physician, so I do see patients. I do touch patients. And for me, what is critical is that they get quality care. And that's one of the things that really affects how people seek services, their perceived quality of the care they shall receive. So it's incumbent on policymakers, on government, to ensure that even when you're talking about access to healthcare under UHC, it is quality care. So the wonderful team here are going to speak to different aspects of what we are looking as comprehensive care, that this specialized service delivery, it has to be patient-centered, equitable access in underserved regions. We're talking about health advocacy, community engagement, academic excellence, quality assurance, women's health, and we'll go quite a bit on that. So I'll go straight into the discussion. And where do I start? I'll start with Dr. Nashwa, I suppose, because you are right on the opposite side of me. And maybe we can just start with you. So she's at Shefa Al Oman Oncology Hospital in Luxor, and you just saw the video prior to this session starting. So from your interactions there and the service that you deliver there, can you highlight how oncology services, and indeed now we are getting to a really specialized area, but how oncology services, though tertiary care, needs to be integrated into UHC to meet rising cancer burdens in Africa? I know you also have a cancer registry, so can you incorporate that just so that we can see how that fits into UHC?
Yeah, good afternoon, everyone. It's a great honor to be with you today. And first, I would like to share the experience of Shefa Al Orman Hospital in advancing equitable, patient-centered, and sustainable cancer care in Upper Egypt. I would like to tell you about the situation of Upper Egypt in 2014. According to the World Bank, there was 80% of poverty is located in Upper Egypt, where 23.6 million of the Egyptian population is located, and also 40% of poverty is there. So, sorry, 80% of poverty is there and 40% of the population. And this is according to the World Bank. And the situation of cancer care, this is before the universal health coverage that was talking about my colleague, Dr. Ahmed Osman. And the situation back then was that there was no available places, and in comparison to the population density, and also there was maybe the equipment is there, but it's even not, whether it's not functioning or it's not even maintained. And also there was lacking of diagnostic services like the PET-CT and also treatment modalities like the radiotherapy. And here, Urmana Charity organization stepped in 2014. Urmana Charity is the biggest charity in Egypt. When they started to before, and the 57, this is a children cancer hospital in Egypt, and then they moved to Luxor because of this situation, and they stepped in 2014 to have 2 major hospitals. They are operating and treating cancer patients for free. And after this, in 2021, what happened is the universal health coverage was also introduced to Luxor as one of the, in the first phase of the governed rates that the universal health coverage introduced. And as Dr. Ahmed Osman was saying, that there are so many authorities in this, and here that come the very clever idea of the strategic leadership, in that how can we be in partnership with the universal health coverage. And this is because of the financial constraints and the economic situation in Egypt in that time, so that there is a problem in the supply chain. And that's why we thought of how can we be in the universal health coverage, so that they can cover only one governed rate of the 5 governed rates that we are already delivering the service to. And while the new HIC system is still rolling out, there is older financing system, like the on government expenses and the traditional health insurance system. They continue to operate in parallel, and S2H remains a key as a referral destination for in both systems. This coordination between the government and NGO institutions is rooted into one goal, that serving the patient. This is how Shifa al-Urman became under the universal health coverage as well, but it's still treating people for free in the other governed rates of the Upper Egypt.
Absolutely, thank you very much. And indeed, when you even describe the area, the level of poverty there, doesn't mean that they don't need tertiary care. They do need that sort of care. Exactly. And you have to integrate it into that UHC. Exactly. I know in our country, Kenya, if you look at the NHIF system that was there previously in Now Shiv, those who would shout loudest for it are those who were able to get their chemotherapy, to get their dialysis care. Yeah. Because if you're poor, it's a decision of you receive the treatment or you die. So indeed, we are seeing how your hospital is incorporating that. Maybe you can share strategies how you deliver high quality cancer care in Upper Egypt, that typically underserved area. How are you delivering care there?
So Shifa al-Urman is a comprehensive cancer center for adults and children, serving all the population, where we have everything under one roof. So that in sense that the strategic planning is that adding also beside the radiotherapy, the surgery, the chemotherapy, the hormonal treatment, the immunotherapy, adding also the supportive clinics like the cardiology, dental, nephrology, and psychiatry, nutrition as well. This was added to ensure the quality of care provided for the patients, and that the quality of life is accessible to all, not just for those who can pay. Also, we create a patient housing facility for those who haven't or cannot afford the hotels, so that, and they are unfit for hospital admission. And also, we kept tracking the cancer referrals, so that to identify the surface gaps, what is missing in the hospital, And after this leading to new services such as bone marrow transplant and also the advanced surgeries that it provided in S2H. We also established a palliative care and a pain clinic so that no patient is left behind. All the patients are treated under one roof. And also we have running a mobile early detection campaign, and this where the campaigns go to the rural areas on Upper Egypt, tell the patient about the cancer and what are the signs of cancer. And beside this, we have 2 days for the patients, the walk-in patients who want to make the mammography or who are want to seek diagnosis if she's, she wants to know if she has cancer or not. And also, we have introduced the patient navigators and also the social services and medical secretaries for social financial support. We also employing porters and support workers for the disabled patients. And beside this, we want to make sure that our patients are accessing everything, the most advanced techniques as well. That's why we stepped in also to integrate the artificial intelligence in the diagnostics. And I'm happy to announce that we will have the Center of Excellence of Artificial Intelligence in Diagnosis and also in research. And also, not only this, we expanded into research and biobanking and the clinical trials as well, because we find that research may bring the patient the hope for, the better survival. Besides this, we launching the telepharmacy and on our way in the telemedicine, as well as we developed a mobile application to manage appointment and schedule and even the patient question so that can be answered. And also we have strengthened the partnership of the Universal Health Insurance, and also we are participating in the national presidential initiatives to widen the access so that to make sure that everything for cancer is offered under one roof.
So really, that's a depiction of patient-centered continuous care at every level, right from the community and striving, looking through, all parts and even including those who can't, who have nowhere to stay. You're thinking about them as they come in for that treatment. All right, so I'll just move on to one of the next panelists. Vivian, you are in the area of health advocacy, community engagement, accountability, and governance. So you've heard from Nashua, they're actually going out into the community. You're from Nigeria Health Watch, and my question to you is, how do you advocate for quality to be viewed not just as a technical concern, but as a citizen's right and accountability metric? How do we turn it to the other side?
Thank you for that. Thank you for that question. I think often there is a focus, and patients focus more on, or people focus more on access. And of course, access is important. Accessing healthcare is critical. But the access is not complete if the access to healthcare is not involving quality care. And what people often understand to be quality differs. So you may have a health facility, but how are patients even understanding what quality means? If we think about the 6 dimensions of quality, is it patient or people-centered? Is it equitable? Is it efficient? Is it timely? Often, you go to a health facility or mothers go to have antenatal or they take their children for immunization, and you're spending half the day there. That time dimension is not often seen as quality. So something we do at Nigeria Health Watch is we have what we call our Community Health Watch initiative, where we work currently in 2 states, in Niger and Kano State. And we basically provide a mechanism for mothers, for patients. Often I always say mothers because it's often women who go to these health facilities. Let's just say for patients, to report back on what the experience was when they go to a health facility. So we have what we call an integrated community listening project, where we use multiple mechanisms to understand what people are experiencing when they go to the health facility. So it's integrated because it involves in focus groups, it involves key informant interviews, It involves also looking at social media and other means to gather people's insights on what experience they had when they go to a health facility. And this is a way to also hold the local authorities accountable for the delivery. So using that information, we now will report back, or we feed back to the state health ministries of health and share with them what patients are reporting back in terms of accessing care. So it does two things. It provides patients with an empowered platform to speak about the quality of care they received. It also provides a mechanism through which we can now use their voices to share what the issues and challenges were, and also to highlight what is it that they want. So providing that platform means there is a feedback mechanism. You're making sure that there's accountability for quality service delivery in those health facilities. So sometimes issues they come up with is, with the health facility we reported back, there was no fence. Something as basic as that was lacking. So through the work we did, a fence was now erected. And when community members see that action is being taken, when they're able to use their voice to advocate for what they want, having that fence repaired, as an example, shows that they're being listened to. And also it empowers them to think, what are some of the issues they're experiencing that they maybe can address? So a borehole is not there in health facilities. So that means what? Lack of clean water, which is an important dimension of quality and access to quality healthcare. So what we do using our platform is providing a voice for community members who don't often get listened to, and also for the state ministries of health to be accountable for quality of delivery in their communities as well.
Oh, brilliant. It allows then the civil society to monitor improvements from what they are asking for. So within, as you said, in service delivery, yes, there's the patients who are getting the care, there's the government that's regulating the whole area, but there's also another group who need to give feedback. Who are the frontline healthcare workers? Do you have any insights from them in terms of quality gaps, especially in rural primary healthcare settings, that you could share?
Yes, certainly. I mean, I'm sure most of us can understand in this room that healthcare, often in our rural communities, is where really the rubber hits the road, specifically because often you mentioned healthcare workers. In many of the health facilities where you're supposed to have at least a doctor, you're supposed to have a nurse, you're supposed to have a lab technician, these cadres of health workers are often missing. So you often have one officer in charge, one lady who's in charge of an entire PHC, primary healthcare facility, and she has to do the antenatal, she has to do the immunization, she has to treat infants when they come for malaria or whatever. So they're often overworked. And they don't often also, similar to what I mentioned about patients, get a platform or a mechanism to actually report back what are some of the issues they face. But also some of the things they face are as basic as they don't have any ongoing training to help them improve their skills. They're not remunerated. They're working, but nobody's paying them. We often talk about community health workers, and that community element negates the fact that they actually need to be paid. And many of them are not. So it's seen as, you're a voluntary health worker, so voluntary doesn't, it's not just that the voluntary means you're not paid. So some of the things that often they raise as issues is, they're not being paid for the work they do. And, all of us in here know, if you're working, you want to get paid because you have responsibilities for your family. So those are often some of the things we often do. Looking at an area, we talked earlier about why we need to prioritize maternal health care. Nigeria, unfortunately, compared to all our other African brothers and sisters here, we have one of the poorest maternal health outcomes. And what that often means is you don't often have the critical health workers there at the health facility when the mother needs to give birth. The midwives, they're not there. So there's some work we did in Kano State where we actually held a policy dialogue, bringing together the state health leaders. And one of the things we're absolutely advocating for is increase the number of midwives that are there at the front line to support mothers when they're about to give birth. So really, I think what we have often focused on and as an advocacy organization is how can we fill those information voids and provide those platforms to advocate for these critical things that, lead up to, universal health coverage. Everybody has access to healthcare whenever they need it and not be financially disadvantaged. So using our platforms and the convenings we do, we provide that feedback mechanism between citizens, and decision makers who are there to provide, to make sure that healthcare is there for people when they need it most.
Thank you, Vivian. In fact, the picture you've painted of, that health worker, I have literally encountered that same healthcare worker in Kenya, a nurse running a clinic somewhere in Lamu. Lamu is an island. And it was just sad to hear some of this. She said she had not been on leave in more than 2 years. She was the nurse. She was the one dispensing the medication. She was the one who was doing registration, and you think, how do you expect someone to deliver quality care in that sense? So indeed, what you're doing is something maybe we can all learn from, because that we need to advocate, we need to speak out for that. But now let me turn a little to Rashid. And we've seen the video of the Aga Khan University Hospital in Kenya, real state of the art. Maybe you can just share Aga Khan University Hospital's commitment to protocols, professional development and research in improving outcomes. Because now, along with the fact that like in Kenya, you're the only JCI accredited hospital, in terms of your institutional experience with that accreditation audit and continuous improvement, how are all those working towards ensuring quality care is what our patients receive?
Okay. Good afternoon, and thanks for having me, and thanks for your question. I'll approach this quality from a very different angle. Tens and billions of dollars are going out of the continent to other parts of the world in terms of medical tourism, and we all know that. And why do people leave Nigeria or Kenya or Uganda to go to other parts of the world? Because either the care is not available, or the care is not available of high quality, or the care is not available consistently. These are the reasons that people go out. When we analyze the African countries and when we analyze Kenya, we will never be able to compete with the likes of giants of India and China, because their economies of scale do not exist. 50 million people versus 1.4 billion people. In Nigeria, 200 million people versus 1.4 billion people. Everything is produced locally in that part of the world. Nothing is sadly produced in this part of the world. Everything is imported. So we will never be able to compete on cost. The only place that we will be able to compete is quality. So we made a conscious decision in 2013, so 12, 13 years back, that we want to be of high quality and high standards. And we can stand on top of Mount Kilimanjaro and say that we are high quality, but that means nothing until it is externally verified. So we chose to go with Joint Commission International, the American quality standards, the gold standard, which is of highest order. And we made that conscious decision so that we can give confidence to ourselves, and more importantly, we can give confidence to the patients that if you're coming to the Aga Khan University in Nairobi, Kenya, you will get the same quality of care as you would get in North America or you would get in Europe. So I think that's the confidence that we have to give. The point number two is, because we are a university hospital, the quality of care that we provide is not only impacting the patients, it is also impacting the students who are going to be doctors and nurses for tomorrow. So if they are learning the right practices, they will practice when they become doctors, when they become nurses, and when they go out in the field, they will practice the right medicine. And then that quality of care will spread across the geography. So that's how I would see quality.
Brilliant. Indeed, right now, I think your medical school, which started recently, everyone's looking towards it to see what quality of medical students you're going to produce. Already you're doing lots of fellowship programs and master's programs, again, at that high quality level. Maybe you can highlight the use of AI diagnostics, telemedicine, remote monitoring in health service delivery. Are you doing any of that at your hospital?
Yes, we are. But, excuse me, a couple of years back, we made a decision to go live with electronic health record system. Again, we were the first in Kenya to go live with medical record system. We went with Meditech US. From end to end, from nursing documentation to the physician documentation to the surgical notes to the PACS system, we went live completely. Because we know that the future it will be based on technologies and machine learning and those algorithms. And if your clinical data is on paper, then you will not be able to overlap the technology on top. So we went live with the Meditech system 2 years back in November 2022, almost 3 years now. And now every electronic data, every patient data is electronically available. 700,000 patients walk into my hospital every year. So that's a very busy hospital. Now that data is electronically available. Now we are working on various algorithms and machine learning platforms so that we can now use those tools to better diagnose, to better care. We will be going live with digital pathology in the next couple of months. We are partnering with the University of Michigan on colorectal cancer. We have a grant from NIH. So sky is the limit. When we talk about AI and machine learning, there are just so many. If you go to any app store, there are thousands and thousands of applications. Some are good, some are just garbage. We will have to pick and choose. We cannot do everything, and we should not do everything. So we are focusing on 3 or 4 areas. We are focusing on cancer care. We are focusing on heart diseases, where we want to be center of excellence and use technology in those areas.
So your EMR, does that span across also your clinics? Because you do have outpatient clinics
Yes.
besides the hospital.
Yes,
So
thanks for
the records
reminding.
across, does it run across? Because
Absolutely.
we are talking about bridging that care, from that primary to tertiary level. Is there a connection?
Absolutely. So thanks for reminding me. Yes, so besides the 300-bed hospital, the video that we saw, we have around 54 outreach centers in Kenya and Uganda, and those are expanding. Our electronic health record system, we went live with the main hospital as well as the outreach centers. So if a patient is seen in Lamu, the example that you gave, and the patient has to be referred to the main hospital for a surgery or a procedure, they don't have to carry the files, they don't have to carry the scans. Data is electronically available. The doctors will be able to see in Nairobi what the MRI reports are, what the lab reports are, what the clinical notes are, and then the care will continue.
Thank you so much for that. So Mokati, let me move to you. And this is the powerful part, women's health. So would you argue that maternal and reproductive health services should be the litmus test for UHC success?
Thank you so much for the question. Good afternoon, ladies and gentlemen.
It's not open.
There you go.
Thank you so much, Jacqueline, for the question. Good afternoon, ladies and gentlemen. It's an absolute pleasure to be here in Abuja. So let me maybe start with a quote from Michelle Obama, which actually summarizes why women's health should be the litmus test. She said, communities, countries, and ultimately the world is only as strong as the health of their women. I think that's a very powerful statement that actually shows that women's health is a critical measure of success of the health system quality. So let me use then maternal and reproductive health to demonstrate this point. If we think about maternal and reproductive health services, it's a compelling lens to look at UHC because it can and should be evaluated. And this is normally where governments try and look at how efficient they are in terms of universal health quality. And these services actually are deeply integrated and they showcase equity, quality, accessibility, as well as financial protection. And I'll share 4 reasons why women's health, and particularly maternal and reproductive health, should be considered as the litmus test for UHC success. Number 1, women's health services highlight the systemic equity because this particular area disproportionately affects women, especially those in low-income countries and those who are marginalized, right? And if the universal health coverage delivers comprehensive and equitable access to these services, it's a signal that the health system is addressing these disparities. It's also a signal that we are reaching those vulnerable communities. And the reverse of that is true as well. And secondly, maternal and reproductive health outcomes are quite sensitive indicators of service quality. If we look at maternal mortality, it doesn't just reflect the availability of care. And Vivian touched on this as well, that it speaks to the timeliness of care, it speaks to safety as well as coordination. One of the most heart-wrenching statistics is that Africa attributes to 66% of all maternal deaths that occur globally. And this is something that is quite preventable. So by, again, ensuring that there is skilled healthcare workers as well as traditional birth attendants, because there are still communities that have, traditional birth attendants. If they are well skilled to ensure that it's safe for the mother to give birth, then that is great. Access to emergency obstetric care is also critical. So is postpartum follow-up, along with postpartum contraception, because that also has implications on child health as well. Now, moving on to point number 3, we spoke earlier about the out-of-pocket issue that we face across the continent, with some of the countries having as high as 80% being out of pocket. And you can imagine that when we think about child birth and maternal care, this can actually be catastrophic to families if there is complications that need to be addressed. So we should have a system that doesn't force women to choose whether to feed their families or to access care. It should just be given, because otherwise it creates financial barriers for them. And lastly, if we think about maternal and reproductive health services, these are foundational to the broader public health outcomes, because they don't only influence the women's well-being, they also influence the health and survival of infants and children. And if we think back to what was shared earlier about the young population that we have in Africa, we need to safeguard that, right? So it's important to recognize the impact of ensuring that the universal healthcare system is successful, because it has more long-term impact on population health as well as economic development. So if we think about it, maternal and reproductive health services embody all the principles of universal healthcare. It embodies equity, it embodies quality, as well as the financial protection that we spoke about earlier.
Thank you so much. I think that's a brilliant way to look at maternal and reproductive health being a litmus test for UHC. I know we know that AHB discusses of private sector business. So how does Organon then collaborate with governments and NGOs to expand contraceptive access, to reduce maternal mortality? I think it's the role of private sector in this delivery is important.
Absolutely. So as Organon, we actively engage with governments and partners across the continent, and many of our partners are in this room. And my role actually is to ensure that our access program, which is aimed at expanding access to modern contraceptives, is accessible across the continent. And we don't only look at supplying the commodity, we also integrate ourselves in terms of being part of the ecosystem, helping to overcome and support efforts to strengthen the ecosystem. So some of the examples that I can share with you is that, for example, we have a program that's running currently with Pathfinder, which is aimed at the young people, ensuring that they learn more about their bodies, and it's called Empowering the Future. and this is implemented in Huarimba. They don't only learn about their bodies and that, they also learn, they also learn about period poverty. So they are taught skills to create their own sanitary towels. They are provided with life skills, and they're also given the learnings about entrepreneurship. And that's a good way to start them young, right? And we also recently partnered with AFRIAN on SRH watch parties in 6 states in Nigeria. And this is like finding fun ways to reach young people where they are, ensuring that they have access to the right information. And this is a youth-led movement. Therefore, it means that it's amplifying the voice of the youth, and at the same time, it's also coming up with solutions that are for the youth, by the youth, and with the youth, because that integration is critical. So we invest quite heavily in, partnering on health system strengthening, on capacity building, on improving access. And one of the challenges that we've been facing was around the stock outages around contraceptives. As we know, the need for modern contraceptives, more than 54 million women have that need. So we have listened to what the countries had to say. We've expanded our operations, and I'm happy to share today confidently that we do have supply available, and we continue to support efforts to expand beyond just that. The counseling has to be of quality. Women are looking for respectful care, and the healthcare providers need to also be mindful of that as well.
All right, so we will go to our last round of questions for the panelists, and it will be just a brief one question each, and then I'll open it up to the audience in terms of any questions you may have for the panelists. So Nashwa, as I wind up with you, we saw the video of your hospital, and indeed there is quite high-tech equipment in there. Can you perhaps tell us a little bit about investments that are needed to maintain high-tech equipment and specialized personnel in a resource-constrained environment? We are trying to integrate this, but we know that those are quite costly. Maybe you can just briefly highlight that.
Having a hospital that's having 25 beds and inpatient beds, this is without the ICU and the high-tech technology. So the people are the real infrastructure of this hospital. So that sustainable cancer care is not built only in the machines, but also the people. That's where we build the training workforce for our physicians, for physicists, for the nurses, for the clinical pharmacists, and also that we are also accredited from the American Association for Continuous Medical Education, and also the Arab Board and Egyptian Board of Egypt Medical Council. And our mission was clear, is to develop a world-class cancer care, and thus we invested in advanced diagnostics like the PET-CT, the MRI, the digital pathology, and also high-end treatment unit like the linear accelerators, brachytherapy, and fully occupied laboratory that also including the research department, where we're having from the DNA extraction to the next generation sequencing, and also operating theaters as you saw in the video, and the ICU, and also the cyclotron. And that we know that owning high-tech equipment is not enough, so that the strategic planning was toward how can we maintain this through the biomedical engineering personnel and the IT personnel. And beside this, we made training for the biomedical engineering and for the IT department, they can maintain and the local surfacing inside the hospital. Beside this, the part of the electronic medical record, how are we maintaining our electronic medical record? Our electronic medical record as well is in-house made system. So this is tailored according to the physician needs. So this allows us to eliminate the license fees and also respond rapidly to workflow changes and cybersecurity. So, and we have also made for this financial, constraints that you're saying, we also went into environmental sustainability projects where we also focused on installing a solar energy and also a sensor-based water taps and lighting reduced utility use and decreased the water consumption by 19%. And also we have brought our own shredder for medical waste that's saved like $20,000 annually. And also we converting our vehicles to natural gas and reduced emission. And this allow us to be the first green hospital accredited in Egypt, as well as we are accredited from the General Authority of Healthcare and Accreditation. This is internationally accredited by ISCOA, and we are on the way of the accreditation from the GCI. Proudly next year, maybe while we are with you, we can say that we are also accredited from the GCI.
Thank you, thank you. Indeed, their investment is in the people.
Yeah.
In the people who maintain that equipment, but also looking at sustainability, which is, I think, critical to all our businesses wherever we may be. Rashid, maybe you can just close off with the role of academic institutions in UHC. So the role of academic institutions in UHC in terms of embedding education and research within health system strengthening strategies.
It's an important question. In Africa, if you look at the majority of the population is living in rural areas. If the UHC really wants to be UHC, then the fruits should reach the rural areas. The biggest challenge in the rural areas is the availability of human resource, what my colleague was also saying. For UHC to be successful, you have to have the right quality of people who are deployed everywhere. And sadly, in African countries, we are also facing with brain drain. People from Australia, UK, Canada, they take our doctors. The grass is always greener on the other side. The smell of pounds and dollars is better than the naira and shilling. So people do go. So who will then treat us? Especially in rural areas. Urban areas in most geographies are very well covered, but the rural areas, that's where the challenge is. And the problem in the rural areas is not the first degree doctors, it's the availability of the specialists, be it neonatologists, be it oncologists, be it neurologists, be it a cardiologist. That's where the academic institution comes in. The academic institutions will ensure that the factory is running. They will ensure that there is high quality of education. And then those people who are trained within the academic institutions will go out not only in urban areas, but will go out in their villages and in their communities, or rotate at least in those communities as well, so that the universal health coverage actually remains universal and is not confined just to the urban areas.
Thank you indeed. Education, very key. And you're getting the education to those who are right there in the communities where they're serving. So Mogadi, for you, in terms of sustainable financing models, how does private sector innovations then support national UHC agenda? UHC is not just the government, it's private sector. How are we creating that so that we reduce that out-of-pocket burden?
So indeed, the matter that we face currently, if we look at what has happened in the financing space, it's critical that we start to explore ways in which we can have more sustainable systems and financing for healthcare. So as Organon, we're actually working with multiple organizations that have more expertise in sustainable financing space so that we can support governments in terms of coming up with solutions that would be relevant for them. So we are open to meeting with the relevant stakeholders and then supporting as we work through the sustainable financing piece. And linking that to maternal and reproductive health, it's critical that we also start to build business cases around why it's important to work hard to prevent some of the unintended pregnancies, because ultimately these are also putting a massive burden on the healthcare system. So it's important because investing in family planning is not just about spacing families, it's a development best buy. And it's a winning investment for governments. If you look at the amounts of money that can be saved through that, but also then be reinvested so that it can support the SDGs that they're wanting to achieve. And it's important as well to realize that we can accelerate achievements across the 5 SDG themes: people, planet, prosperity, peace, and partnership. So, you know, Dr. Samkeli Sodube, who is the executive director of FP 2030, summarized this very well. She says, for every dollar invested in family planning, the benefits to family and society are estimated to be at least $8 minimum. And I believe this is an unprecedented investment, right? So as we think about the pillars of sustainable financing, and we think about the key strategic pillars for reducing maternal mortality, but also building sustainable health systems, let's remember to bring family planning into the core, integrated into primary care and integrated across the chain as one of the strategic levers that governments can pull. Thank you very much.
Thank you. Thank you. And finally, Vivian, just one line on how storytelling can influence policy and shift perceptions to empower communities. You're the health advocate. I have to throw that one at you.
No problem. So just to conclude, I think our platform, Nigeria Health Watch, we use the power of storytelling to surface a lot of the health issues that, if told in a normal journalistic, heavy data, using jargon, you lose people. People identify with other people's experiences. So on a weekly basis, we use our platform to publish articles that use the power of storytelling to advocate for a lot of the issues people face in the community. So if a family or if someone goes to a health facility, and how do you give them a platform to share that experience? But also linking it back to policies that should exist to address those issues. So infusing and using storytelling, infusing that with policies that exist. I mean, Nigeria, we are very good at coming up with policies, so we're not short of policies. But often that policy gap in implementation poses a challenge. So really using the power of storytelling, the articles, I mentioned the Community Health Watch work we do, where we have community reporters who actually report those stories, using radio also as a way to kind of surface some of these challenges, is a way we use our platforms to make sure that, that people are better informed about health. Because I'm sure if most of you open the newspaper, the last thing you're going to start looking at is health stories. You often turn to the back and look at sports for men or politics. Those things drive eyeballs. Those things drive interest. So health is not often a topic that creates a lot of interest. But we all know that without health, then nothing matters. So we use our storytelling platforms to really elevate those issues and to really translate a lot of these issues into a way that's easy to understand for the average person.
So thank you very much to all my very able panelists. I think they have given you a taste of, academia, specialist care, women's health, and actually community engagement and advocacy on how we can actually deliver quality healthcare services. I'll hand over to Mary Musa, who's giving me the terrible eye, but we are done. Thank you, Mary.
Thank you. Never, Dr. Jacqueline. We can actually have you and the panelists there for the rest of the day. Honestly, such a rich conversation and such a thought-provoking conversation. And I'm hoping that we can see the complementarity of each of your area of expertise. Again, to achieve universal health coverage, none of you can do it alone, but we can all do it together through collaboration. And I want you to view, again, Africa as a whole. We are all here to support each other and learn from each other. Thank you once again, and a round of applause. Before we conclude, I want to say you will receive a report about this session, but meanwhile, please reach out to us, AHB team. Let us know how we can take this conversation forward. We should not stop here. We definitely need to continue conversating, to continue finding solution. And this is one special of many special elements about Africa Health Business, is that we catalyze the conversations and we push it forward. So please be proactive and let us know how we can promote this conversation. It has been my honor to chair this session on comprehensive services and quality of care for achieving universal health coverage in Africa. As we conclude, let me just pass through a few ideas that we have heard from our panelists. Of course, through Dr. Jacqueline as well. So we have heard about data-driven advocacy as highlighted by Vivian, Nigeria Health Watch, and how it can uncover the gaps and guide equitable investments, especially for the underserved population. And I can quote her saying that they have been filling the information void that we can have. So please leave no void. Let us collect our own data. Let us advise our own decision-making processes. And if I can also quote Mukadi, thank you so much. Always I feel proud listening to you, trying to empower women at every level, at every community. She has emphasized on the private sector innovation, exemplified by organ-on partnerships, which is critical to expanding access to essential services like contraception. Again, women should not be trying to choose between their food and between their health care, and they should be able to support their families and themselves. Allow me also to mention Aga Khan University Hospital main role in advancing how we offer services to our patients. Rashid, you're inspiring us all, to be honest. And you have mentioned academic excellence, data collection through real-time information. I'm impressed by your abilities, by the abilities of your institution, which supports accurate decision-making and health system integration, as modeled by AKU. So, Mr. Kalani, thank you so much once again, and keep leading, definitely. Last but not least, Shifa Al-Orman, Dr. Nashwa, we are really impressed by the efforts of the Al-Orman Foundation. And again, we are here to follow your story, how you're going to push for sustainability, to avail healthcare for the needy, for the most vulnerable communities, but also as you provide for those who are in need, you're providing equitable and of quality health care. You're not providing the bare minimum. So thank you so much for leading by example. Again, allow me to actually ask you to step down for a group picture. And for all of our esteemed participants, let us commit to scaling all the models that we have witnessed today and we have heard about today, leveraging data, fostering public-private partnerships, prioritizing patient-centered care to achieve universal health coverage. And again, let's continue this dialogue. Let us know how we can promote this conversation. Meanwhile, as we stand for the group picture, allow me to invite Ms. Natasha Gilani, who's going to be our esteemed and dynamic colleague who's going to chair the next session.